Thanks so much for being here with us, Dr. Fontana. And he's going to be discussing acute liver failure.
Sure. Well, thanks. Good to see everyone virtually, and hope to see everyone in person here soon. Sarah and I are both rounding, so maybe I will bump into some of you here in the next 2 weeks. But I realize it's actually, I think, been a couple of years since I've had a chance to talk with the newer fellows and faculty. And so Sarah asked me to talk about this, which I think is a good topic to review because it's not the most common thing that you'll see in the ICU, but yet there are some kind of clinical nuances to managing these patients together. So without further ado, I guess I'll go ahead and get started. So what I'd like to cover with you here in the next hour is to review with you, the definition of fulminant hepatic failure or acute liver failure and how that differs from cirrhosis. And then specifically go through what we know about the causes and how the causes determine prognosis. And the most common being acetaminophen overdose. And we'll talk a bit about, when to use NAC, not just for acetaminophen patients, but for non-acetaminophen patients. And then really the unique and interesting but complicated pathophysiology here of cerebral edema, which develops in these patients, and when to consider placing an ICP monitor and the kind of ICU kind of interventions that you may consider. And then this is usually in the continuum of, is this patient going to need a liver transplant? So I think for clinical context, we need to discuss that as well. Excuse me. So just, to kind of get us all on the same page of a definition, acute liver failure is uncommon. It's a rare but dramatic illness. And we specifically define this in a very narrow way of the onset of a coagulopathy defined as an INR greater than 1.5 and mental status changes in a hospitalized patient. That's relatively short duration. For sure, less than 26 weeks. Most of these are less than 8 weeks, and many are just within a few days. And the patients should not have pre-existing liver disease. So this is very different than the patients probably in the CCMU right now who have cirrhosis with mental status changes and high INRs, or septic patients with DIC and intrahepatic cholestasis, alcoholic hepatitis, and so on. So that's a whole different, pathophysiology and talk. So really sort of focusing in just on these acute liver failure phenotype. And the reason that we call them out is that their natural history is different, and they can rapidly deteriorate. They can die of uncal herniation within a few days of presentation. And ICU care is improving, as I'll show you, but there's still a concern of, poor outcomes in the absence of emergency liver transplant. And quite remarkably, doing emergency surgery in these patients, they do quite well, probably because most of them are on the younger side and don't have a lot of medical comorbidities. But they get about an 85% one-year survival compared to about 93, 94 for our chronic patients undergoing transplant. Now, if you want to know about evidence-based management of a rare disease, you're really going to have a super narrow view of this entity because it's very rare. 1 to 10 per 100,000 people per year, 2 to 3, 4,000 cases total in the US. So that might be 50 cases, 60 cases in the whole state of Michigan. And so because of the rarity, not surprisingly, there's very few randomized controlled trials. But if you want to know what's been proven in this disease entity, NAC has been shown many years ago for APAP overdose to have efficacy and is standard of care. I'll show you the data for non-APAP patients. H2 blockers back in the 90s were shown to reduce bleeding in the ICU. There's never been a study, believe it or not, with PPIs in acute liver failure patients. CRRT was demonstrated to be better tolerated with probably a little better efficacy than hemodialysis due to less hemodynamic stress, 30 patients. And then mannitol many years ago was compared to no mannitol in patients with cerebral edema, and it led to reductions in ICP, but again, small study, 30 patients. We actually know more so what doesn't work in larger trials. So there were actually two moderate sized clinical trials, about 100, 150 patients, testing steroids in non-acetaminophen acute liver failure, and neither one of them showed any efficacy. And there was a slight increased risk of infection. So that's why we don't give those kind of across the board. Enteral decontamination to prevent bacteremias and complications didn't work. Charcoal hemoperfusion back in the 80s and 90s didn't work. And then more modern methods like using an extracorporeal bioartificial liver that has either porcine hepatocytes or human hepatoblastoma cells in a dialysis cartridge didn't work. And even a simpler device like the Mars or albumin dialysis was tested in a multi-center study in France, and it didn't improve outcomes. So we actually know what not to do. We have a little bit of data on what to do, and the rest of it is largely expert opinion based. So from a study group that I've been involved with for over 20 years, we've accumulated quite a bit of data in American adults. This was a pass of the data a few years ago where we had over 2,000 adults enrolled at 20 major medical centers, including our own. And this just gives you first the view of the terrain or the landscape of this entity. So the first point in this slide is that acetaminophen is the #1 cause. It's about 50% of all the patients here in the blue bar. And the rest of them are all smaller players with idiosyncratic DILI and indeterminate being #2 and #3. And then in the black dots is the spontaneous survival here on the y-axis on the right. And the reason this is important is that acetaminophen patients are the most common. And they also have a pretty good survival with supportive medical care, about 70%. Pregnancy patients actually have very good outcomes. Hep A's do generally pretty well. And the shock ischemia patients do pretty well from a liver perspective. So those are the favorable etiologies. And then we know that these like patients with autoimmune, DILI, Hep B, and indeterminate, they don't do well. So that's why we like to know quickly what's the cause of acute liver failure, because it's going to give us some prognostic information right away. So how do you arrive at a diagnosis? Remember, these patients already have impaired mental status, so the medical history may be patchy or minimal at best. Sometimes they come to us intubated, so we really have no ability to talk to the patient. But, you look for the common things. Drug and toxin exposures, either per report or family, etc. We like to get objective biomarkers like acetaminophen levels, urine drug screens, etc. That should be in every patient. Viral hepatitis, you can't tell. So you got to test for Hep A, IgM, Hep B, surface antigen, and HB core IgM. And then these other diagnoses really require, I think, a hepatologist to help you out. Autoimmune hepatitis is kind of a complicated one where you have to have autoantibodies, hypergammaglobulinemia, and a compatible liver biopsy. Pregnancy-related causes almost always occur in the 3rd trimester. And there's the HELP syndromes and toxemias and fatty liver pregnancy. And then there's even rarer things that are less than 5%, fulminant herpes, severe CMV, malignant infiltration, for example, with like a breast cancer or unusual leukemia. These are all very rare. And then, as you may know, we're a center of excellence for Wilson's disease, so we're always looking for it, but it's less than 1%. And this requires a combination of diagnostic strategies. But Chiari as a cause of acute liver failure, very rare. You have to lose the venous outflow simultaneously in all 3 hepatic veins. You diagnose that through imaging. And then here in Michigan, we don't worry too much about rhabdomyolysis, but if we were in Texas or Southern California, they see it from like the equivalent of heat stroke. And then hepatic ischemia, we see quite a bit actually with the sicker cardiovascular patients. So the other way of looking at etiologies is what can you do if you find a particular cause? So we particularly want to know about acetaminophen overdose because, as you know, there's a role for rapid lavage of the stomach if you identify a patient within 8 hours of oral ingestion. There's also a role for activated charcoal to block absorption, and then NAC that we'll talk about in a minute. These are always interesting cases. Amanita mushroom poisoning. They tend to occur more on the coasts, like upper Pacific in California, where there's many more of these mushrooms and people inadvertently eat the wrong mushroom. There's a whole medical protocol here of trying to get the toxin out through lavaging of the stomach because it's enterohepatic circulation. You can also give IV penicillin and dialysis. These are very rare, like, 1 in about 500 of acute liver failures. Autoimmune hepatitis patients are theoretically treatable with steroids, but we got to be sure about that diagnosis. But Chiari, there's always a thrombophilia, always, when you thrombose all your hepatic veins. So there's a role for heparin. Hepatitis B, we give entecavir to reduce the viral load, because many of those patients are going to end up with the transplant, and reducing their viral load is of benefit, even if it doesn't save them from a transplant. Fulminant herpes, there's definitely a role for acyclovir. Pregnancy, it's almost always, rapid delivery of the fetus. But remember that some cases of acute liver failure occur after the delivery, and supportive care is generally what's recommended there. And then Wilson's disease, there's just too much copper circulating, causing a crisis. And there we have a couple of faculty in our division where we have chelators and plasmapheresis as well. Now, again, it's acetaminophen. This is number one, and it's been number one in our prospective database for 20 years. And if you extend this out to 2020, 2021, 22, it's still about 40 to 50% of all cases in adults in the United States. So how does this happen? Well, it's just too much of a directly hepatotoxic substance, which is acetaminophen. Now, how much is too much? For sure, more than 6 grams, if you took that much at a single time point. Gets a little bit more complicated when people are taking, multiple acetaminophen products over, say, several days for a medical indication. And then if you're fasting, you can deplete your intrahepatic glutathione within 24 to 48 hours. Alcohol further, facilitates that, and also enhances, oxidative metabolism to the hepatotoxic intermediate of NAPQI. So those can be cofactors in a given case. But clinically, these patients usually have very high transaminases, oftentimes more than 1,000. That's not specific, though. Most of them have low bilirubin levels, unlike viral patients where their bilirubin levels will be high. So we rely a lot on blood acetaminophen levels if it's a single time point ingestion, and that's the RUMAC nomogram that I'll show you in a minute. But remember that if you're jaundiced, some acetaminophen assays are colorimetric, so you may get a false positive low level acetaminophen level if you just check it in anyone who's jaundiced. So this is the RUMAC nomogram, is published almost 40 years ago now, hard to believe. And this is basically the blood level of acetaminophen and the time after ingestion. And if you have a low level relative to the time in which you're drawing the blood, you don't tend to get hepatotoxicity. And this is pretty reliable. Then there's patients who are above it, where you're likely going to get hepatotoxicity, meaning abnormal ALT. And then there's patients in the intermediate zone, like any other prognostic model, where there's a possible risk. Now, it's important to go back and look at this study, because this was way back 40 years ago. All the patients were known acetaminophen overdoses. They all got oral NAC as a standard of care, and the outcomes were quite good here. Less than 1% of the patients died in the late 70s, early 80s. And the few who died, they tended to have high transaminases and a delay in NAC. But if you got the NAC within 8 hours, you had 0% mortality. So again, this is a highly treatable entity, and use this with known single time point ingestions. This does not work, though, when you're chronically overdosing, because that's not how the model and the data were developed. So do not rely on the acetaminophen level when you hear that someone's been taking Tylenol number 3 for several days, because it does not have the same prognostic implications as it does with a single time point ingestion. And either way, whether it's known intentional overdose, single time point, or staggered, you're going to want to give NAC as soon as possible. I mean, this should be starting in the ER, EC3, etc. We like to use oral when possible. You give a loading dose and then 70 mg per kg. every 4 hours for up to 72 hours. But you will get some GI distress. We know that because it's a sulfa drug, right? So you're going to get some nausea and vomiting. So you could give some prophylactic Zofran or Compazine or wait, IV fluids, etc. But some patients will be GI intolerant of the oral route. So there is an intravenous formulation called Acetadote. That's the brand name, but it's basically N-acetylcysteine. We definitely recommend it if you have a short gut because you'll malabsorb, or you have a known ileus, or you're pregnant, to get the blood levels up as quickly as possible and protect the fetus. The loading here is a little bit different, and this is all in my handout of IV infusion, 1 hour, 4 hours, and then 19 hours. But beware that you're giving an IV sulfa drug with this product. So you can get anaphylactoid reactions, a little bit of a rash, tachycardia, a little bronchospasm. So these patients need to be in a monitored environment if they get IV acetadote. And obviously, if they have known overt, bad sulfur allergy, don't give IV acetadote. Now, once you've identified the cause, you then have to medically manage the patient. And there's some general measures that we recommend for all acute liver failure patients in the ICU. So first thing is that they should be in the ICU because they can rapidly deteriorate and they need careful monitoring and frequent labs. So frequent labs means every 8 hours, serial LFTs, INRs, and factor V, which has the shortest half-life and is the best prognostic marker. Renal failure is very common in this patient population, and they may need CVVH. Arterial blood gases are also very helpful here to see which way the lactate may be going, as well as serial ammonia levels. Hypoglycemia is relatively common in this patient population because you're losing your ability to maintain glycogen synthesis in the liver, so you can get hypoglycemic. So you need to be aware of that in testing with chem sticks, etc., and supplementing. And then the question frequently comes up, well, this patient's intubated, they're hypoglycemic, should we consider them for a transplant? What's the role of a biopsy? Does the percent necrosis on a biopsy correlate with outcomes? And the answer is no. And it's also very complex to get biopsies in these coagulopathic patients. So we do not recommend a biopsy for prognostic reasons. We will occasionally get it for diagnostic reasons like the autoimmunes, herpes, cancer, etc. But it's a small number of patients that we need the biopsy for diagnosis. So this was a RCT that we were involved with over 10 years ago, where there was some pilot data to suggest that NAC may be useful for non-acetaminophen acute liver failure, but no one really knew. So we did an RCT, 170 patients enrolled, from over 828 were screened. It took a long time to do this study, 8 years. These were largely autoimmune, DILI, hepatitis B, and indeterminate acute liver failures. They were randomized by site. I think there were 13 sites, coma grade, stratified randomization, and then patients continued with whatever the standard of care was, intubation, dialysis, transplant, etc. So this was superimposed on routine care. We projected that patients who got NAC would have a better 3-week survival than those who got placebo. That was the hypothesis. And then we were looking also at secondary outcomes here. So what do we find? Well, survival was trended to be better, but it wasn't statistically significant, and we had adequate power. So it didn't meet the primary outcome, getting NAC versus placebo. However, transplant-free survival, which was a planned secondary outcome, was significantly better. That is, the patients who got NAC were much more likely to survive at 3 weeks without a transplant versus those who got placebo. And this was particularly true in those who had mild encephalopathy enrollment versus those who had advanced encephalopathy. Remember, these are all non-acetaminophen patients who generally have a poor prognosis. So the greatest difference in transplant-free survival was in those with grade 1 to 2 encephalopathy. Now, over time in this large database, we've been tracking outcomes. And again, this is sort of amalgamated data from multiple centers over multiple years. We published this in 2016 in Annals. And what we showed, interestingly, was that overall 3-week survival is improving in the United States from 60% back here in 1998 to almost 75 to 80% in the mid 2013, 14, 15. And this was true across the board in terms of overall survival. Was also true when you look at, in the black line, transplant-free survival, and also whether you looked at, groups like ours that have been in the study the whole time or groups that came and went. So very curious that, ICU care appears to be improving and outcomes in these patients are improving over time. So the question is why? So again, remember, this is descriptive associative statistics here. So NAC use in acetaminophen overdose, which again is 50% of the patients, increased. It was surprising. It was only 80 to 85% in the late 1990s of known acetaminophen overdose patients. But here in the blue was really what changed. When we published the study, it was actually presented in 2008, I believe, at the liver meeting. The word got out pretty quickly, so lots of intensivists started to use NAC and non-acetaminophen patients. So you can see here that this is the proportion of patients who got NAC for non-acetaminophen acute liver failure really went up quite a bit to 60 to 70%. So is the prior slide due to this slide, or is it due to this slide, which is we're giving more NAC for non-acetaminophen acute liver failure, but we're also doing less ICU interventions, which we know can have some adverse consequences, like intubation went down over time. Giving plasma went down over time, quite a bit, actually. Blood transfusions went down over time. And then here in the black is ICP monitors. So whenever you have an observational study, it's not causative, it's just purely associative. So are the better outcomes because we're, smarter in ICU care with less transfusions, less intubation, less intervention, or is it because we're giving NAC to more patients? We can't really tell. Now, one of the things that is sort of a problem with these patients is infections, because not only do you not synthesize clotting factors, you don't clear hepatotoxins, but you lose the Kupffer cell function in your liver as well when you have acute liver failure. So 80% of them are going to get bacterial infections. They can be bacteremias in up to a quarter from common gram-negative rod, strep, and staph. Sources are respiratory, GI, and urinary. And then the dreaded fungal infections, which tend to occur a little bit later in the course, but can happen on broad-spectrum antibiotics when the patients become febrile, hypotensive, and more leukocytosis. So infections are a big deal here. So we use broad-spectrum antibiotics with any concern of infection, meaning unexplained elevated white count, left shift, unexplained deterioration of fever, etc. So most patients end up on broad-spectrum antibiotics. We like cephalosporins and quinolones with vanco over aminoglycosides due to nephrotoxicity concerns. Fever is a real challenge here. We don't want to be using acetaminophen, but you can certainly use cooling blankets. And then if they're on, CRRT, you can also sort of adjust the temperature extracorporeally. Coagulopathy is a hallmark of this condition. It's complicated. Lots of these patients have low platelet counts due to reduced thrombopoietin generation in the sick liver, all the drugs they're getting, and even acute portal hypertension with splenomegaly can drop your platelet count. The hypoprothrombonemia is due to the liver hepatocytes not working and not synthesizing. If they've been jaundiced for a while, we always want to give vitamin K to see if it improves. And then they can have DIC either due to poor clearance of the products of coagulation or active infection. It can be really hard to tell. Now, interestingly, despite the fact that these patients have a multifactorial coagulopathy that's usually pretty profound, I mean, I've seen INRs 5, 6, 8, 10. Bleeding only happens in 10% of patients. And the reason that probably is the case that it's not everyone's bleeding or 50% or 80% is that there's a rebalancing of your hemostasis. And so not only are you not making the procoagulant factors, you're also not making the inhibitors. And the body seems to know how to reset with the low net rate of bleeding. When you bleed, it tends to be in the GI tract, and other mucosal surfaces. And we recommend the PPI, even though, again, I told you there's no RCT, it's standard of care. Now, we don't, though, just give blood products to these patients. And again, overall bleeding risk, this is from prospective data, is low. We only transfuse if they're actively bleeding, or if you're planning to do an invasive procedure. And here the goal would be to try to lower the INR to less than 1.5 and platelets greater than 50. And then if they're hypofibrinogenemic, to give cryo. And then we have a special protocol that I don't have time to go over of using recombinant 7A prior to an ICP monitor placement. Now, of note, the bleeding that happens, most of it is spontaneous, even though it's only 10% versus procedural. But whether you bled or not didn't impact on your survival. So just because someone is needing some transfusions doesn't mean, you know, that it's necessarily too late. Now, that was what we knew. So we thought, okay, what about the ROTEM, right? You know, since it's a complex pathophysiology here, maybe the ROTEM, like total net clotting, right? The clotting time and the alpha angle and the fibrinolysis, this might be better as a global marker of hemostasis. So we did a prospective study, 102 acetaminophen patients, 90% non-acetaminophen. We just published this a year ago. And what we found was there was a very low rate of bleeding events and a very low rate of clotting events. So there was no correlation at all between any of the ROTEM parameters and bleeding or clotting, but both of those were low incidence events. So then we said, well, maybe we're looking at the wrong thing with coagulation. So we looked at coagulation in relationship to outcomes. And there was some significant differences. So this is transplant-free survivors at 3 weeks, and these are people who needed a transplant or death. And it's kind of hard to, you know, do so many correlations, but as you know, when you do a ROTEM, you get 4 parameters of the clotting time, the FibTem, the INTEM, and the XTEM, right? And so what we did here is we plotted out, this is admission, day 2, day 3, day 4, and day 5. And we said, well, what's the proportion of abnormal ROTEMs? Because again, your FibTem can be abnormal, but your XTEM and your INTEM can be normal, or you can have 2 of the 4 abnormal, et cetera. And so to show the data, what we did was this matrix plot. And in general, when you look at this just from a color perspective, the transplant-free survivors, few of them had abnormal ROTEM parameters on any of the days. Whereas the patients who died or got transplanted, the darker colors here, particularly the red, were more common. So actually, ROTEM parameters were associated with outcome and severity of the liver failure, but they didn't correlate with bleeding risk or clotting risk. So therefore, we don't know how to use these, for example, to guide blood product infusions in our ICU patients. So I just share with you that that's where we're at in terms of our knowledge base currently. Now, many of these patients, as I mentioned, are going to need a transplant, and this is all done in parallel with the ICU management. So we're going to be seeing everyone. We may then call the transplant surgeons if we think they need a transplant, or to assist with the sort of determining candidacy. And one of the first things we're going to focus in is what's the cause and where are they at in their natural history. And of course, what's their medical background? Do we have any sense of compliance? So getting families here right away at the bedside and so on, and having our social workers help out is really important. We're going to do a bunch of testing right away, and we can usually get most of the medical evaluation for a transplant done within about 12 hours with a couple of consults, a bunch of blood tests, including 2 ABO blood types, as you know, because to list someone for a transplant, you have to have 2 in our blood bank. We're going to want to do surveillance cultures, probably start broad spectrum antibiotics. What imaging do we need? They need a chest x-ray if they haven't had it done, a liver ultrasound Doppler to look at the portal vein. And then from a cardiac perspective, as to transplant candidacy, obviously an EKG, and then we like to have a bedside echo, because if there's any LV or RV dysfunction, that may impact decisions regarding transplant. Now, as you're working the patient up for a transplant, you also got to be thinking about managing their cerebral edema. So how does cerebral edema occur in this entity? We're not entirely sure of the pathophysiology, but there's a good amount of work in animal models of acute liver failure that there's probably 2 phases. The first phase is when you get the rapid loss of hepatocytes. There's a lot of circulating neurotoxins, including ammonia and ammonia-like products that are normally removed by the liver, but when you have fulminant hepatitis, the liver's not working. And so when those then circulate through the blood, they impact the blood-brain barrier through mechanisms that we're not sure how that happens, but the blood-brain barrier becomes leaky, and the ammonia and ammonia-like toxins are able to get into astrocytes. And then once astrocytes see high levels of ammonia, they try to conjugate it from glutamate to glutamine to help remove it from the body. It's a neuroprotective mechanism. And then what happens is when there's lots of moles of ammonia around, the amount of glutamine increases in the astrocytes and they swell. And you can actually see this again in an animal model. We haven't really been able to study this that well in humans. And when the astrocytes swell, then they bring fluid in with them and you get cellular cerebral edema. And as you know, when you have cerebral edema, then what happens physiologically, the CSF, the pressure goes up intracranially, pressure in the CSF goes up, and there's a pushing, right, of the fluid down into towards the spinal cord, a dilation of the ventricles. And if this goes unopposed and you don't intervene, you will then herniate the tissue and the cerebellum and get a herniation of the brain, and you'll get brain death. Though the mechanisms that lead to, ultimate herniation and loss of autoregulation of blood flow probably occur later than these earlier cellular changes in the parenchyma of the brain. So clinically, what does this look like? So these were previously healthy people. They can kind of fool you, but when they're getting sicker, they're usually going to become confused or incoherent or agitated or somnolent, significant mental status changes. And here you now have to worry about them protecting their airways, so they may need to be intubated. They're likely going to start to need hemodynamic or renal monitoring, because as the brain starts to fail and the pulmonary system is failing, kidneys are oftentimes failing in parallel. And then you need to be thinking about, well, should I be putting a bolt in this patient? What about if they're on propofol? Are they seizing? And where are we going with the transplant? So in these patients, there may be consideration of not just a CVP, but even a SWAN. And the reason is that you don't want to over-resuscitate them with more fluid, even if they're hypotensive, because more fluid will exacerbate the cerebral edema. So many of these patients end up on low-dose pressors. They're oliguric. It's really hard to tell their intravascular volume status. So like I say, invasive monitoring is still, I think, has a role in these patients. And then if they need to be on CVVH or renal replacement therapy, we prefer CVVH over HD. And interestingly, many of them, as you know, don't need citrate anticoagulation, but we obviously defer to our renal colleagues on that. And as this is happening, your goal now in the ICU is changing, and that is to maintain cerebral perfusion pressure of at least 50 to 60. And as you know, that's calculated from your mean arterial pressure minus your ICP. But obviously, without a monitor in, you don't know what the ICP is. So if you need to push up the MAP, we prefer Levophed over vasopressin from small studies. And then we want to avoid surges in ICP. So Valsalva maneuvers, suctioning, high PEEP ventilation can increase intracranial pressure. So we want to avoid all those. And something really simple to do is to keep the head of the bed of the patient. You got to write an order to not let it go below 30 degrees, because just by dropping their head down, they can get a surge in increased intracranial pressure, and it worsens the whole cycle. Now, ICP monitoring, as a medical doctor, is kind of what I would want, because there's all kinds of discrepancies between the things that we normally look for, like, CAT scans, cerebral edema and papilledema and so on. And then many of them are intubated and sedated, so we have no physical exam to go by, and so on. But the pushback on placing bolts in everyone is that there's no data that bolts will improve survival. And then there's a risk of obviously placing the monitor. So what's the data on this? So this again is from our study group from a prolonged period of time, 7 years, multiple centers. And so this is purely observational, but the numbers are I think, reasonable. 489 patients who did not get a monitor in the ICU with acute liver failure and 140 who did. You can see that we collectively as a group tended to monitor younger patients. They all had really bad coagulopathy, and the way that they were able to get the monitor in was, again, a combination of FFP and usually recombinant 7A in most medical centers to normalize the INR to put the monitor in. Most of these patients were intubated, grade 3, 4 encephalopathy. Many of them were already on renal replacement therapy. And we tended to be more aggressive in patients who were listed for transplant. But as you can see, there were many patients who were listed who didn't have an ICP monitor. So what happened? Well, in the ICU, there was an opportunity to intervene more, to try to manipulate that CPP. So monitored patients were more likely to get mannitol. They were more likely to get hypertonic saline. They were more likely to get barbiturates to slow cerebral metabolism, and they were more likely to also receive kind of salvage hypothermia. So there were more ICU interventions when you know what the ICP is. Interestingly, when you put the bolt in these very sick people, only 50% actually had a documented intracranial hypertension. So not everyone, who's intubated grade 4 is going to necessarily have it. The problem is all your non-invasive studies don't help you. In terms of complications, there were, 7% rate of intracranial bleeding. Some of these were minor and didn't impact outcomes, and there were 1 or 2 catastrophes. So this is, a serious complication. We've done probably 30 or 40 of these here now in the last 10 years. We have had 1 or 2 bad complications, but for the most part with our neurosurgeons, we've done quite well. But when you looked at outcomes, remember, this is not an RCT, it's purely observational data. Overall survival was about the same. Now, what about hypothermia? I know that you use it quite, regularly for post-cardiac arrest and other situations like that. So the sort of critical care literature starts with the more common things, and then it gets into the rare things. So there's small studies of trying to use hypothermia in acute liver failure patients. The method is not entirely clear what's preferred. I think intravascular cooling is a problem in these patients because of the coagulopathy. Perhaps the cooling blanket or Arctic suit may be better. There was one study from way back in 2004 from King's College that they were able to get 13 or 14 patients on hypothermia through a liver transplant, which created a lot of excitement that this may be a useful modality. So we studied our outcomes again in the United States. Quite a big cohort here, 1,125 patients who did not get hypothermia in the ICU, 97 who did. And it was usually after the run-of-the-mill interventions didn't work, so the hypothermic treated patients were tended to be sicker. Interestingly, similar rates of infections, similar rates of bleeding, which, as you know, is something you worry about when you induce hypothermia, particularly in these patients, and overall outcomes were the same. So again, we don't have any data that it's harmful. How helpful it is, we don't really know. When you cool someone, as you know, also the body will tend to shiver. So, I found actually in the patients, some of them that we've cooled here, propofol usually prevents it, but sometimes you need to consider then using atracurium and checking CPKs, et cetera. So really what we need is a randomized controlled trial of hypothermia versus no hypothermia with ICP monitors in. But that has not been done. And then we need to know, if we're cooling someone, how long do we cool them? How do we warm them? Is there any impact on liver regeneration, et cetera? So this is ripe for a clinical trial, but to my knowledge, no one has done this to date. What we have done and accomplished in the study group is I think we've developed some pretty useful clinical bedside tools that you can apply today if you happen to have a patient like this. So you may recall King's College published their prognostic criteria back in the late 1970s, early 80s. And that was all based upon this ICU in London, where they tended to get all the cases from the UK. And they published it and everyone quotes it. And it's been validated, et cetera. So we said, well, okay, that's good, but what's happening in the US now? So we looked at all of our data, and we had over 2,000 patients in this analysis, multi-center, so it's kind of attractive. And what we found was actually the King's College criteria were not very good in US patients with modern medical care. The area under the ROC curve here was 0.652. In fact, the MELD score did better than the King's College, but what really did better than both of them was our own index, which was a combination of the severity of encephalopathy, the etiology, which I've shown you some of the preliminary data, whether you needed pressors or not, your bilirubin level, and INR, and these are both part of MELD, right? So we found that this combination of 5 variables clearly was superior to the MELD score or the King's College score in American patients with acute liver failure, and we published this in 2016. So this is available, and I hope all the fellows will download this onto your phone so you have it when you're on call. It's a free app that we made to make this translatable. And this is what the app looks like when you download. It's called the ALFSG prognostic score. And it'll basically ask you, what's the encephalopathy grade of your patient? What's the cause of their acute liver failure? Are they on pressors, yes or no? And their bilirubin and INR. So you can do this in like 5 minutes, and it'll give you a likelihood of spontaneous survival at 3 weeks. Now, like any model, it's not going to be perfect, but it's one more tool you have at the bedside to see, where this patient is at clinically. So ICU management, again, if you have a bolt-in, we do not want to have the ICP certainly higher than the MAP because you're going to get cerebral hypoxia and irreversible brain damage. And unfortunately, if this goes on for too long, as you know, the patient may become brain dead. And we have had to, unfortunately, do the technetium 99 scan, even in patients who we had listed for liver that we weren't able to find them one in time. And they died of brain death right in front of us. Very, very troubling when that happens. There may be other reasons that we can't move to transplant, even though we initially thought. So if they get uncontrolled sepsis, which is why we're very vigilant about cultures, but also giving antibiotics. Severe multi-organ failure. If someone ends up, on 80 to 100% FiO2 in renal failure, and you're trying to do a liver transplant, you're not going to be able to get that patient through the OR, and that unfortunately happens from time to time. Refractory hypotension, same thing. You can't induce anesthesia if you're on triple pressors, or if they've already, had a catastrophic bleed into their brain. Fortunately, this only develops in about 10%. And as we get greater access to organs for these super sick patients, I hope it goes down even further. So speaking of transplant, the way it works is, we're obviously a transplant center, and we have the ability to list our patients. And these days we draw from an even larger geographic area. It used to just be the state of Michigan. Then it was Michigan, Indiana, and Ohio. And now our net is even bigger. We can go out to 500 miles from Ann Arbor, which is a pretty big geographic distance. It goes all the way to New York and Minnesota and St. Louis. So it's a pretty big area that our surgeons can try to find a liver for these patients, and they go to the top of the list. And they're usually looking for an ABO compatible whole liver. We don't do partial grafts here. But still, you can wait a while. Like if you're blood group B, there may not be a donor available for some time. This does happen, though, about 200 transplants a year in our center. We might do 3 or 4, so it's not that common. And quite remarkably, these are almost always intubated on CVVH, critically ill patients undergoing emergency surgery, and they do amazingly well. I mean, 85% 1-year survival. So we clearly want to be aggressive, and that's part of our transplant program. Now, here's one last slide just to sort of be provocative and realize there are things that we can do as a medical group and culturally. So the FDA has been aware of, acetaminophen overdose for a long time. And there's been a lot of calls to them to regulate acetaminophen more so, because as you know, you can buy acetaminophen in lots of places. You can buy it in vending machines, supermarkets, the airport. There's over 1 billion tablets consumed a year. So this is the most commonly used drug in the world, but yet it's also intrinsically hepatotoxic. So they've met multiple times to say what kind of regulations should they impose, because remember, there's a lot of people who depend on acetaminophen for analgesia and anti-inflammatory effects with chronic arthritis and headaches and things like that. So it's an effective drug. It's just that if you take too much, you get into trouble. So back in January of 2011, they held an advisory committee meeting, and they published a new regulation that they told the manufacturers that for combination acetaminophen narcotic congeners, the most amount of acetaminophen you can have in that is 325. And the reason is there were forms of Vicodin and Vicodin ES where there was as much as 750 milligrams with each dose of the oxycodone and other narcotic. And people would take multiple ones of those for pain, and then they'd end up with liver failure. So it's avoidable if you reduce the amount of acetaminophen in those combination products. And so they came out with this requirement of industry that they were not allowing it to be on the market anymore after 2011. And they had to give the manufacturers some time to, reformulate their tabs and all that. And they did. And so this is an interesting epidemiologic study where it's coming out in JAMA, it's been accepted, where we looked at the national inpatient sample, which, as you may know, is representative of, the whole United States, where you can look at ICD-10 base codes to say what's the, trends over time in the US. And there are ICD-10 codes for acetaminophen plus opioid toxicity, as well as acetaminophen toxicity alone. The numbers are a little bit concerning here. So in this time period, between 2007 and 2020, there were a total of 39,000 cases in the United States of acetaminophen plus opioid toxicity, the combination drug toxicity. Almost 500,000 cases of acetaminophen overdose alone. And this analysis was trying to look at the potential impact that this FDA regulatory action had on the incidence. In other words, did it work? And it looks like it did, because you see here's 2011, this is an inflection point, that the incidence was rising prior to this, and then they implemented it in 2011. It took about 2 years for industry to get all the products changed, and lo and behold, it's gone down. But it's not zero, right? So this is still happening, but the good news, at least it's on the downward side. The disturbing news to me as a hepatologist is that we still have so much acetaminophen alone overdose. This is about, 60 to 70,000 cases a year, or 500,000 over 12 years. And interestingly, in the paper, we worked with this investigator, and we looked at the ALFSG over the exact same time periods to see if our data was representative of national data. And sure enough, we saw almost exactly the same inflection point in 2011, and it started to come down in our ALFSG patients. And same thing, acetaminophen was sort of unchanged. So I think this is a real phenomenon. It shows you the power of public health in improving health outcomes. And whether or not the FDA is going to take another swipe or remove acetaminophen from these analgesics, that's up for debate, and certainly something that may happen in the future. So with that, let me finish up here to summarize for you. In 2023, we know acute liver failure is a rare illness, dramatic outcomes, multiple etiologies. That's why it's so hard to remember. But I hope I've emphasized with you the importance of making a rapid diagnosis, and we all work together with these patients. So if they're rolling in tonight at 3 o'clock in the morning, we want to get those serologies done. We want to get that ultrasound, Doppler, et cetera, as quickly as possible. Treatment, we want to give NAC to anyone who you think could have acetaminophen overdose. If you think so, give NAC. It's not going to hurt. It may help. Transplant-free survival, as I showed you from our database, is improving. That's fantastic, but we don't know why. I didn't show you this, but there is more and more CRRT being used in patients with lower levels of creatinine who have acute liver failure. So maybe this is a good thing. It's hard to tell when you have trend data, but there's less use of suppressors, less intubation, less transfusion. And that's a good thing, I think, across the board with medical ICU management. But these patients still can get cerebral edema and sepsis. So hence, I still think there's a role for highly selected patients for ICP monitors. And, the field in neurocritical care is moving away from mannitol, and we're almost exclusively now using hypertonic saline. And we'll have to see, is that better? That's largely from the closed head injury experience that we're kind of moving in that direction. And that transplant, isn't effective for selected patients. But again, we'd like to get these patients over here, transferred to the CCMU as quickly as possible when we hear about them, so we can do all this rapid evaluation and medically manage them while we're trying to sort it all out. So obviously, this is a huge amount of work that I presented. This is the acute liver failure study group a few years ago. This is me over here. This is Will Lee, who's the overall PI, and Todd. We've been kind of co-managing this for the past 10 years. This is one of our meetings when we used to meet in person. And with that, I'll stop and thank you for your attention and see if there's any questions.